everyone. Welcome to the Multiple Myeloma 360 series, part 2, where we're going to be talking about side effects and how to mitigate those, particularly in the relapsed refractory setting. My name is Tiffany Drummond. I'm a patient advocate with over 20 years of experience in cancer research, and my journey began as a caregiver when my mother was diagnosed with endometrial cancer in 2014. I quickly realized the challenges of finding resources, support, and shared experiences, and now I'm committed to helping others no matter the condition. That's why we at The Patient Story create programs like today's to help you figure out what comes next. Think of us as your go-to guide for navigating not only the cancer journey, but your overall health journey. From diagnosis to treatment, we've got you covered with real-life patient stories and educational programming with subject matter experts. I genuinely am your personal cheerleader, and I mean that, here to help you and your loved ones best communicate with your healthcare team as you go from diagnosis through treatment and survivorship. Before we get to our speakers, we want to thank our sponsor for its support, which helps us to host more of these programs for free to our audience. The Patient Story retains full editorial control over all content, as always. I must also thank all of our promotional partners for your support. It is because of you that our programming reaches the audience who needs it. I hope that you find today's program helpful. Please keep in mind that the information provided, while encouraging and engaging and insightful, is not a substitute for medical advice. Finally, we know that there's more topics that you want to talk about and discuss, so let us know what those are and how we can do better about getting that information out there. A survey will pop up after the program ends, so make sure you don't go anywhere. So without further ado, let's kick off another amazing conversation. Today, we are joined by two panel experts from Mount Sinai's Tisch Cancer Institute in Manhattan, New York. First up is Donna Catamero. Donna is the Associate Director of Myeloma Research, and she is a nurse practitioner specializing in the treatment of multiple myeloma patients. I am so happy to have her here. And you might not know, but me and Donna go way back. Okay, so we used to work together back in my regulatory days. We also have Abby Reiser. Abby has a unique role and is part of the multidisciplinary team at the Cancer Institute. She is a dedicated dietitian nutritionist, and she is also board certified as a specialist in oncology nutrition. I think it's such a critical role, and I'm definitely excited to hear her insights today. But moderating this conversation is going to be Valarie, and Valarie is a multiple myeloma survivor and thriver and an inspiration to many. Valarie, I also actually, was kind of reading up on you. I did not realize you are a breast cancer survivor too. So your journey is just one of inspiration. You've come so far. And so thank you again for agreeing to be here today. So I'm going to let you take it away, Valarie, and I'm excited for this engaging discussion.
Awesome. Thank you. Thank you so much, Tiffany. As Tiffany said, I am a myeloma and breast cancer thriver. I've been on the myeloma journey for about 9 years, breast cancer journey for about 5 years now. And I can definitely understand the issues when it comes to treatment side effects. So I am so excited to be here and having this conversation with these two ladies this afternoon. Now that I've shared just a little bit about myself, I want to welcome everyone to the program. We're here today to discuss relapse and refractory multiple myeloma and how to manage the side effects of treatment. Now, to start with, Donna, can you explain the difference between relapse and refractory disease? I get this question a lot, and it can be kind of confusing to some of the patients.
Yeah, because most patients are both relapse and refractory. So relapse is when a patient has an initial response to therapy. So they're either in a complete remission, partial remission, or a very good remission. And their disease starts coming back. So that means they're relapsing from their response. Refractory is that patients are on a therapy and they start to relapse. So that means they're refractory to that therapy. And so for most patients, most myeloma patients are on a continuous therapy. So when they start to relapse, they're going to be a relapse and then refractory to the current treatment they're on. So most patients past their first line of therapy are going to be relapse refractory.
And when we think of relapse refractory, what are some of the common, symptoms of that? Is it just like when we are first diagnosed with myeloma? Is it some of those same symptoms and things, or is it totally different when it comes to the relapse refractory setting?
So patients fall into two categories. So some patients have a biochemical relapse. So what that means is only their numbers are going up. So we monitor myeloma patients with their labs, we look at their protein levels, and we see an increase in their protein levels. And so, but otherwise the patient feels fine. It's just on paper, we see that their cancer is coming back. Or a patient can have a symptomatic relapse. So they're symptomatic from their relapse. So they're either more anemic, have new bone disease, new renal insufficiency or kidney disease, or elevated calcium in their blood. So the typical CRAB symptoms that we say are the symptoms of myeloma. So they either have those symptoms or they might not have any symptoms at all. And we're just seeing the cancer in their blood work.
Okay. And what are some of the current treatment options for relapse and refractory multiple myeloma?
So this landscape of treating relapsed refractory myeloma is so quickly evolving. We have so many new therapies. In this past 5 years, we've had so many drug approvals for multiple myeloma patients in that relapse setting. So it's a very exciting time. So we have more targeted approaches with proteasome inhibitors like Kyprolis, Velcade. We can use those in the relapse setting, but more novel mechanism of action, so more targeted towards the immune system, so bispecific antibodies for patients who've had 4 prior lines of therapy, and then CAR T therapy, which is another immunotherapy, which is very exciting for patients. And now it was initially approved for patients who had 4 prior lines of therapy, but now we can use CAR T in patients after 1 prior line of therapy. So really these novel approaches to management of relapsed refractory disease.
Awesome. I know I always get excited when I think of the therapies that we have since I've been diagnosed, and even the therapies that's in the pipeline. It's so much, given us so much hope as patients out there. So, Abby, how can a well-balanced diet specifically benefit multiple myeloma patients undergoing treatment?
So, diet recommendations often change throughout treatment based on how patients feel and if they experience any side effects that affect their appetite and or their ability to eat. For multiple myeloma patients who are feeling and eating well, the nutrition recommendations are the same that we would recommend for most other cancers, which is also consistent with the recommendations for the general population. So, plant foods like fruits, vegetables, whole grains, beans, nuts, and seeds contain a variety of cancer fighters, including vitamins, minerals, fiber, and phytochemicals. Phytochemicals are these naturally occurring compounds in plants that have the potential to stimulate the immune system, reduce inflammation, and fight infection, making these foods especially beneficial for patients to consume while undergoing treatment. Protein can also help to boost the immune system, as well as to promote healing and to build cells, tissues, and muscles. We encourage choosing a variety of both lean animal-based and plant-based proteins, including chicken, fish, turkey, tofu, beans, and nuts. The current plant-based eating model recommends filling 2/3 or more of your plate with plant-based foods and 1/3 or less of your plate with animal proteins to create a well-balanced meal.
And are there certain nutrients or dietary patterns that can help manage side effects like fatigue and anemia?
Definitely. So, patients who do experience side effects from treatment may find it difficult to follow a plant-based diet to a T. Fatigue is one of the most common symptoms among myeloma patients and one of the most common side effects of treatments. I typically recommend staying as active as you can, eating often and adequately, drinking plenty of fluids. Try planning ahead by asking for help with meal prep, trying meal delivery services, and keeping ready to eat snacks on hand like nuts or granola bars or pre-made protein shakes. When it comes to nutrition recommendations for anemia, the truth is anemia is commonly caused by the disease, treatments, or kidney dysfunction caused by multiple myeloma and cannot be improved by diet. However, nutritional deficiencies such as iron, B12, or folic acid can also be a cause. and this can be improved by supplementation, either orally or by injection. It also couldn't hurt for patients with these deficiencies to increase their intake of foods rich in these vitamins and minerals, such as turkey or sardines, lentils and beans for iron, again with lentils and beans and spinach for folate, and fish and dairy for B12. I typically encourage patients to talk to their doctor about the cause and plan of care for anemia before making any significant changes to the diet or starting a new supplement.
I often hear as a patient, we're told to kind of eat the rainbow. Is that something you recommend?
Yes, if their appetite is good and they're feeling well and they can eat a variety of fruits and vegetables, I'm all for it because they're going to get different nutrients from different colors. So that's definitely a recommendation that is still staying strong to this day.
Eat the rainbow. Awesome. And hydration, we often hear about the role of hydration. Can you discuss that role in managing side effects of multiple myeloma treatment, such as kidney function and even oral health?
Definitely. Staying hydrated during myeloma treatment is essential, especially because dehydration can worsen kidney function, which is a common concern due to the disease's impact on the kidneys. Drinking sufficient fluids helps to flush out waste products and manage potential complications like high calcium levels, which can occur with myeloma. Bispecific treatments like talquetamab can cause oral toxicities, including dry mouth, mucositis, and taste changes, and good fluid intake plays an important role in managing these side effects. I typically recommend aiming for at least 8 to 10 8-ounce glasses of low sugar fluids per day. Plain water is the gold standard, the preferred beverage for hydration, but other beverages such as seltzer, decaf tea, coconut water, and lower sugar electrolyte drinks can also promote adequate hydration. Caffeinated beverages like coffee, tea, and colas, as well as alcohol, may worsen side effects like dry mouth, so I recommend limiting those.
Are there any specific dietary considerations or restrictions that myeloma patients should be aware of? I know you just mentioned the alcohol and the caffeine, but are there any things that they should strictly avoid, or certain foods or drinks like that?
A couple limitations really apply to every type of cancer. One being we recommend limiting red meat, such as beef and pork, to less than 18 ounces per week, and avoiding processed meats like bacon and sausage as much as possible. I also recommend limiting processed foods that are high in fat, starches, or sugars, such as chips, cookies, candies, cakes, and sugary cereals. Patients should also limit sugar sweetened beverages like juice and soda and avoid or limit alcohol. General guidelines recommend no more than 2 alcoholic beverages per day for men and 1 drink per day for women, but I typically defer questions regarding alcohol to the doctor. Multiple myeloma and its treatments can weaken the immune system and increase risk of infection, which can make patients more susceptible to foodborne illness, which we often call food poisoning. Therefore, it's important to follow food safety guidelines while on treatment in an effort to reduce infection risk. General tips include washing your hands well, separating ready-to-eat food and raw meats, checking expiration dates, refrigerating leftovers immediately, and avoiding high-risk places like salad bars and buffets, and high-risk foods like raw rare meats, runny eggs, unpasteurized dairy, sushi, and unwashed fruits and vegetables. I also discourage against the use of supplements unless you have a deficiency or you're told otherwise by your medical team. Supplements don't offer the same benefits as eating whole foods. They're typically not regulated by the FDA, and research tends to be limited in terms of how they may interact with treatment. So for patients who are hoping to start taking a supplement, just make sure to check with your doctor before doing so.
And any advice you can provide about green tea? Like, I know with some of the treatments, they say avoid green tea on the day that you're getting treatment or a few days afterwards. Is anything that you can speak about on that?
That's usually discussed if they're on Velcade, but I know, Donna, you and I talked about this before. I believe it's the supplement, the green tea supplement, that you really need to avoid entirely.
Yeah, no, it's the high dose green tea extract that you can buy as a supplement, which is contraindicated when taking when on a regimen containing Velcade. But patients, what I advise patients to do with, if they love green tea, just not consume it on your treatment days. Tea itself, the beverage is fine for patients. It's really the supplement that can get patients into trouble.
Okay, thank you for clarification there. So how can a nutritionist help patients manage weight changes? I know one thing that I experienced, with taking the steroids was a lot of weight gain. I know patients deal with weight loss as well, which can be some of the common side effects of treatment there. So, what can we do as far as, from a nutrition standpoint to kind of combat some of that?
Treatment side effects, especially oral toxicities, often lead to decreased appetite and weight loss. If a patient is experiencing unintentional weight loss, I typically recommend having small, frequent meals every 2 to 3 hours and choosing high calorie foods as tolerated. I often will emphasize healthy fat sources like nuts and nut butters, avocado, olive oil, because fat contains more calories per gram than proteins and carbs. I also will often encourage them to make homemade smoothies, shakes, and to drink oral nutrition supplements because sometimes it is easier to drink your calories than eat them when your appetite's low. Low impact physical activity is tolerated, can also help to increase appetite and maintain muscle mass. And then for patients who are really struggling to eat and their appetite has been consistently low, it could be worth asking the doctor if starting an appetite stimulant is appropriate. On the other hand, I also see patients experience weight gain while on treatment. Oftentimes, this is, like you were saying, due to steroids or in part due to steroids or fluid retention. To maintain a healthy weight, we'll recommend following a Mediterranean style plant-based type of diet, which emphasize having lots of fruits and vegetables, lean proteins, whole grains, legumes. We also emphasize watching your calorie intake, monitoring portion sizes, and eating slowly and mindfully. It takes 20 minutes for your brain to get the message that your body is getting food, and then you stop feeling hungry. So the slower and more mindfully that you eat, the sooner you should realize that you're full. I also, again, recommend being physically active as tolerated, specifically to engage in at least 150 minutes of moderate intensity physical activity per week, which can equate to 30 minutes, 5 days per week. And moderate intensity physical activity could be like a brisk walk or biking, things like that.
So one thing that I noticed that, a lot of patients have experienced skin conditions as a result of treatments. One thing that I've dealt with is just the severe dry skin. And I've also had to deal with kind of like hyperpigmentation of the skin there. What are some of the common skin conditions that you all see multiple myeloma patients experiencing as a result of treatments?
Yeah, so some of the treatments we give, because we do a lot of our treatments are subcutaneous injections, so that goes right underneath the skin. So we often will see like injection site reactions. So around the area where we administered the medication, it gets inflamed, red, it can be itchy. So those are your injection site reactions. Other side effects that we see are the dry skin. So for patients experiencing this, and if I know a regimen is going to cause the dry skin, I start telling patients to use those heavy barrier moisturizing creams with the initiation of therapy. So let's not wait till, especially in these long winter months, our skin dries out fairly quickly with the heat. So you want to use moisturizer, again, those heavy barrier creams that can help retain the moisture. So I would start that with the initiation of therapy. When we see these on-target off-tumor side effects with talquetamab, for example, we can see some hand-foot peeling. So on the palms of the hands and the soles of the feet, the skin starts to peel. So with that, again, these side effects can be self-limiting. We can manage these well. So we use lotions like ammonia lactate to the area. We'll do that twice a day. And this typically will resolve in 2 to 3 weeks for patients. So again, self-limiting. Other things we can see is that nails can get brittle and peeling. And unfortunately, there's not something I can give patients that eliminates the brittle peeling nails. But what I can do is suggest those nail polish hardener lacquers that will at least make the nails stronger, so they're less likely to break for patients. We recommend cuticle oil around the cuticle bed, and we're going to look for signs and symptoms of infection. So we don't want to have any nail infections. Other side effects that patients can experience, they can have a whole body rash or a localized rash, and we can, depending on the size of the rash, we can manage quite well with topical steroids, these lotions. If a rash is more generalized, the whole body rash, we'll add on a steroid taper. So a course of steroids over several days, and this will tamper down the whole body rash and typically will resolve again in several days. Itchiness. So a rash can be itchy, or a patient will just feel itchy in general. So we can use antihistamines, Benadryl, but also loratadine or Claritin for several days to help with any itchiness that patients have. And then certainly if this is drug-induced, and depending on the severity of the skin reaction, I'm going to hold the medication until, these symptoms resolve. And then we can resume therapy. And if the rash was severe enough, I would consider either a dose reduction or, look at the frequency of how frequently we administer the treatment.
Mm-hmm. Mm-hmm. Awesome. I think one of the key things that you mentioned there, Donna, is making sure that, you start early with it. That's very helpful to know there. Do you often refer to a dermatologist, or do you treat them within your cancer center?
So early on, when we were looking at these new treatment modalities, we weren't really typically seeing these side effects. So we work very closely with our dermatology colleagues. But then we can manage quite well with these side effects. So I actually manage my own patients, and anything that I feel like I can't manage, I will definitely refer to our colleagues in dermatology. But for the most part, we can manage these symptoms quite well within our own practice.
So let's shift the conversation to a particular class of drugs. Bispecific antibodies are emerging as a promising treatment option for relapsed refractory myeloma. Donna, can you explain how these antibodies work, and have you seen an increase in this approach with patients?
So this is a very exciting treatment modality. It's new, it's novel. We had several drug approvals within the past 2-3 years, with this new class of drugs. So what this is, it's a monoclonal antibody similar to daratumumab, where it's going to bind to a receptor. It's going to bind on the myeloma cell. So it's binding to the myeloma cell. So one arm of that antibody is grabbing the myeloma cell. The other arm of that antibody is going to grab onto the receptor of a T cell. So our T cells are our little soldiers of our immune system. So T cells will do a surveillance and get rid of anything that looks bad in our system. So infections, cancer cells, they're really doing the surveillance and they're eliminating anything that would be at risk for us. So they're our little soldiers. So what a bispecific antibody is doing is grabbing onto the myeloma cell, grabbing onto the T cell, and bringing that T cell close to the myeloma cell so that the T cell can recognize the myeloma cell and kill it. So in essence, we talk a lot about CAR T therapies. It mimics the mechanism of action of a CAR T therapy, but the benefit of a bispecific antibody is it's off the shelf. So there's no downtime waiting for manufacturing for these CAR T cells. This is off the shelf. If I need to start a patient tomorrow, I can do that. So we can start treatments, initiate therapy quite quickly in patients. And we're really harvesting the patient's immune system to attack the myeloma cells. So this is a really exciting new treatment approach for patients.
As a patient, I'm very excited to hear about the bispecifics. So what are some of the common side effects associated with these newer targeted therapies, Donna?
So because we're kind of activating that immune system, right? So the immune system gets revved up. And what happens is it releases these cytokines. So cytokines are little immune substances that will just be released, and it can cause havoc. So it can literally affect every body system. But typically what a patient will experience is they get the bispecific antibody, and they'll have a fever. This can progress to low blood pressure, can progress to a patient having difficulty with breathing. But these are so well managed now. So the typical patient is going to complain of a fever, almost like when we get our flu shots, we feel a little achy, low-grade fever. This is typically how a patient's going to present. And then as providers, I know this patient's probably having CRS, so which is cytokine release syndrome. And again, the immune system is getting all revved up. And so what I'm going to do is just tap the brakes on the immune system. So we have treatments that will simmer down the immune system. And, the patient usually, we intervene, and within 24, 48 hours, the patient's symptoms resolve. And then we continue on with treatment. We try to mitigate this by giving pre-medications. So we'll give Tylenol, Benadryl, some steroid to help mitigate this side effect. But the majority of patients are going to have this side effect. And so typically we do this as an inpatient, but more and more institutions are learning to manage these side effects as outpatients. So I think we're getting really good at managing these side effects, that we're doing this as outpatient now. And so it's just something that we monitor patients very closely. We're monitoring, patients' vital signs, so blood pressure, temperature, and we're intervening at the first sign of a fever, or if I see a patient has a drop in their blood pressure, or difficulty with breathing, we intervene very quickly. Other side effects that we see, so again, the majority of patients are going to have this cytokine release syndrome. And to a much, much lesser extent, we can see what we call neurotoxicity. So patients, if they have a cytokine release syndrome, typically what we see immediately after is neurotoxicity. And what that looks like is a patient might present with some confusion, maybe a little disoriented, can tell you they can name the hospital, they can tell you their name, but instead of saying it's winter, they'll tell you it's spring. So there's some little confusion. Also, we see patients with a change in their handwriting, and this can be actually quite drastic. So prior to starting these therapies, we obtain a handwriting sample. And then we monitor the handwriting sample throughout treatment. And what we'll see is a change from, one 12-hour shift to the next, where a patient will write a beautiful sentence, and then a few hours later, we'll just scribble across the paper. And And then we know, this patient is experiencing a neuro event. And again, this can be scary, but we manage this very well. This is reversible. So we'll manage the patient with steroids. And then, this is self-limiting. So meaning it won't reappear. And this is why care partners are very important when we give these types of treatment, because if the patient is at home, they might not understand that they're confused. So it's very important to have that care partner with that patient to, monitor the patient to see if there's any alteration in their mental status. And again, we manage this quite well with steroids.
And I think you've already addressed this question, Donna, but I want to make sure that I ask it. Are there specific strategies you offer for managing side effects like cytokine release and the neurological side effects?
Right. So to mitigate some of these potential side effects like cytokine release and neurotoxicity, we do two things. So first, we're going to do a step-up dosing approach. So we're going to give a small dose for that first dose, a slightly higher dose for that second dose, and then the full dose typically. So we're not going to give the patient the full dose with the very first dose. So we kind of ease the patient into that medication. And then the second thing we do to try to, again, mitigate this is to have a pre-medication on board. So Tylenol, Benadryl, and some steroids, again, to mitigate this and to mitigate the severity. So most patients are going to have that cytokine release syndrome, but it's typically mild. So again, patients presenting with the fever, which we can manage quite well. The neurotoxicity, it happens in very low percentage. So, less than 7% of patients will have this neurological event. And we can manage it. So again, that step-up dosing and the pre-medications can help, but that's something we will manage when the symptoms arise.
So, Abby, I want to go back to you. I know we talked a little bit about, the diet. And I know that, having the healthy snacks in place can actually help with some of the side effects, managing the side effects. But specifically for patients who are experiencing a loss of taste, that's something that I hear a lot about. How can patients change their diet to really help manage that particular side effect?
Yeah, taste changes is one of the most common side effects that I talk about these days. And it's definitely one of the most difficult to manage because there's no one size fits all approach. There's no one miracle food that everyone enjoys. And there's no medication that provides total relief. So it's really tough for patients to find foods that they enjoy, let alone tolerate. Something I emphasize to everyone, regardless of their experience, is good oral hygiene. Patients are often prescribed a mouth rinse, but if this doesn't help, I recommend trying a homemade rinse made with baking soda, salt, and water, or using an over-the-counter alcohol-free mouthwash. Brushing the tongue and teeth after meals and before bed is also important to keep the mouth clean. And it doesn't hurt to try sugar-free gums or mints to see if that improves any unpleasant taste in the mouth. When it comes to describing taste changes, I hear a wide range of statements, including everything tastes too bitter, too sweet, too metallic, or has no taste, tastes like cardboard, or everything tastes bad. If food tastes too bitter or too sour, I recommend adding something sweet to food like honey or fruit. If food tastes too sweet, try adding an acid such as vinegar, lemon, or other tart, tangy, or acidic flavors. If everything tastes metallic, I recommend using non-metal utensils and cookware, such as plastic, glass, or ceramic, trying fresh or frozen foods over canned, and serving meat colder at room temperature. For bispecific therapies, specifically, I think the most common everything tastes statement is everything tastes bad or has no taste. For this, I emphasize the importance of experimenting with different flavors, textures, temperatures, herbs, spices, seasonings, and sauces, because you never know what might work for you. Specifically, I often hear that adding acids like lemon, lime, vinegar, and tomato can make foods more enjoyable. I'll often recommend adding fresh lemon or lime juice during and after cooking, and adding citrus such as lemon packets or sliced lemons and oranges to water if plain water tastes unpleasant. Taste is really the combination of not only the taste, but also the smell and touch of food. So if you can't get any pleasure from taste, don't underestimate the power of texture and smell. Regarding texture, soft, moist foods like oatmeal, soups, mashed potatoes are usually more tolerable since they're easier to chew and swallow, which means they spend less time in your mouth. Smoothies and oral nutrition supplements are often go-to recommendations of mine because they're quick and easy ways to get in calories and protein. And smoothies especially allow for a patient to experiment. Fruit is one of those things that's often tolerable, so I recommend blending different fruits into smoothies to see if that makes them easier to get down. Animal proteins tend to be really tough for patients to tolerate, so I typically recommend choosing softer animal proteins like egg salad or fish, or marinating and cooking meats in acidic dressings or sweet juices. Many patients report that they maintain their sense of smell despite losing their taste. And I've had a patient say that certain foods like cucumbers and cantaloupe and coffee smelled good to her, which helped them taste good too. So it's definitely worth experimenting in this way. I think an important point that patients should take away when it comes to taste changes is that everyone is different, and one recommendation that works for one person may not work for the other. So it's important to keep trying and retrying foods because you really never know what may end up working for you unless you try. Also, even though everyone is different, if patients are experiencing these side effects, they should know that they're common and they're not alone.
All right, so let's shift a little bit. Let's talk about the emotional side effects, such as anxiety and depression. Donna, I'll throw it to you first. How can patients cope with these types of challenges?
Especially in that relapse refractory setting for patients, with every relapse, causes a lot of anxiety and fear. And starting a new treatment, there's a lot of fear, which then increase in anxiety can lead to depression. So I think having a good social network, support network for patients. We're very fortunate in my institution. We have a wonderful social work team that can really help patients. We have support groups. I feel patients can, support groups work for some patients, not for others. But I think having, care partners and on your team, caregivers, really helping patients through these challenging times. Because I know, again, with each relapse, it's challenging for patients. But the good news is that we do have these great therapies for patients, and it's really providing that support for patients to get through their therapies.
Yes. All right. And Abby, how about you?
From a nutrition standpoint, if a patient's experiencing side effects from treatment that affect their ability to eat, like taste changes, that can significantly impact a patient's quality of life. It can cause patients to feel isolated because it's hard for anyone to fully understand what they're going through. On top of that, they might feel pressure from family and friends to eat more, even when they don't feel well. And I've seen that cause resentment. Eating is such a social and cultural activity, and many patients feel like they don't have a place at the table. To help cope with these challenges, I would encourage patients who are experiencing these kind of side effects to ask for a referral to a dietitian, because our job is to provide tips and tricks to help patients eat despite these side effects. I also encourage them to try to continue living their lives as much as possible, to go out to eat and attend social events when they have the energy and when it is safe for them to do so. And I think a lot of times when people are experiencing side effects and they go out to eat, they feel maybe embarrassed or afraid to advocate for themselves. But I encourage them not to hesitate. Or I encourage them not to hesitate to ask for their food to be prepared a certain way at a restaurant if it makes it easier for them to eat. And if they want to bring their own food when they go out, that's completely okay. I'm sure their friends and family would prefer to see them enjoying their meal and feeling supported rather than feeling embarrassed or ashamed.
Yes, I agree with both of those. As a patient, somebody who's been on that side of it, you have to look out for yourself. If that means taking something to a restaurant in order to have that that time with your loved ones and really be able to enjoy a meal, then do it. And Donna, you mentioned the support groups and maybe support groups not being for everyone. Just know that there's, one-to-one support out there. You can talk with a myeloma coach, you can talk with a mentor angel and various programs like that. But just know that you're not alone, as you're dealing with these side effects, that, others are going through them as well. And you always have someone to support you. Thank you, Donna and Abby, for taking time to speak with me and the Patient Story audience. Do you guys have any final remarks?
So I think we have some great therapies we can offer patients. I think the important thing is getting patients through that therapy. So there's side effects. We're going to help manage those patients through their treatment so they can have the best possible outcomes.
And I would encourage patients who are experiencing any of the side effects that we talked about today or outside of today to speak up, advocate for themselves, and let their teams know. The sooner their team is aware, the sooner they can provide supportive care or treatment to help manage those side effects. And if the side effects they experience make it difficult to eat, don't hesitate to ask for a referral to a dietitian if their team has not referred them to one already.
Yes, I agree with you wholeheartedly there. Just speak up and don't suffer in silence. There's no need for that. Thank you both for doing it. So I'm going to turn the program over to Tiffany to close us out. Thank you so much.
Wow. Thank you again, Donna, Abby, and our patient moderator and advocate, Valarie, for taking the time to discuss mitigating side effects, and especially to Valarie for sharing that myeloma experience. I am really grateful that she not only shared her story, but shared it with the patient story. It takes a village, and I know that your story, Valarie, will resonate. If you are a patient, caregiver, or advocate, consider being a voice leader in your community or with us here at The Patient Story. To wrap up this discussion, I want you to leave with the takeaway that it is important to be empowered so that you and your caregivers can make informed decisions about your care. That includes being educated on the latest on the side effects and mitigating those side effects and getting the support that you need. A reminder, we want to hear from you. A survey will pop up when this program closes. Thanks again to our sponsor for its support of our independent patient program and to all of our promotional partners. Until next time, I'm Tiffany Drummond signing off. And on behalf of The Patient Story, thank you for watching.